Thank you for joining. I'm so glad to see everybody here, and I've seen some familiar faces here, so it's good to see you all here again. Hopefully I can answer some basic questions about endocrine and what some of the care guidelines are right now for it. So I'm going to cover three things. I'll talk about the bones, I'll talk about the adrenal gland, very briefly, and a little bit about reproduction. So let's talk just very basics about bone growth, right? When kids are growing, both cartilage cells and bone cells are important for growth. And chondrocytes are the cartilage cells. And some of the important bone cells are osteoblasts, osteocytes, and osteoclasts. And we'll briefly talk about that. So these bone cells and cartilage cells are affected by hormones. They include like growth hormone, thyroid hormone, androgens, and steroids. So all of these are having a play. So here is just a basic diagram. Basically, all I'm telling you is that growth hormone is there, and it makes IGF-1, which is the subproduct from the liver, which also influences growth. Why am I talking about growth hormone and IGF-1? They actually influence the cartilage cells, the cells that break down bone, which is osteoclasts, and the cells that build bone, which are osteoblasts. So they have a direct effect on all of them. And if when you're in your growing phase, the osteoclasts are less active than the osteoblasts. When there's more bone breakdown, osteoclasts are more active than the osteoblasts. So you more bone breakdown because the osteoclasts are more active. Now, one of the things that I want you guys to be aware of, just decreased muscle mass and strength actually affects bone stress. And this can actually directly impact linear growth. So independent of the steroids or anything else, this is already happening. Now, how much that is, not much, but it can have an effect in the long run. Now, we're talking about steroids largely here and complications associated with it. And as you can see, it has multiple effects, including effects on bone mineral density. It can affect blood pressure, glucose, weight, growth, and reproduction, which is not listed here. Now, when you talk about steroids, steroids basically inhibit growth hormone through somatostatin activity. And this ends up leading to decreased IGF-1. So you have both decreased growth hormone and decreased IGF-1, which ends up decreasing the osteoblasts and osteoclasts in different ways. Glucocorticoids also directly affect the cells itself. So here it decreases the cells that build bone, the osteoblasts. It decreases their activity, and it increases the activity of the cells that break down bone. And you, of course, have an effect on the cartilage cells itself. So all this leads to decreased linear growth and bone strength. And that's the thing to keep in mind when you're talking about glucocorticoids. Now, we check for height, standing height, every 6 months, starting at the age of diagnosis. But what I want you guys to keep in mind is we're always checking for non-standing growth also, every 6 months. And why? Because it'll give us a more accurate assessment as when people stop ambulating, what their growth trajectory is. Now, when should we start paying attention, or when should a patient be referred to an endocrinologist? If their growth per year is less than 1.5 inches, so that's when you start trying to start paying attention. Or their height is less than the 3rd percentile. Now, they can be assessed for endocrine abnormalities, including growth failure, because of the medication itself or some other cause. Now, impairment can happen, particularly if you have daily administration of glucocorticoids, which most of our people are on, and that's of concern, right? So that's why we need to be aware of this. And because they're on glucocorticoids, a lot of patients can experience short stature. And this can be of concern to the patient, social impact. While it may be beneficial for the patient care in the long run, it may not be great socially. Now, there's few data on human growth hormone in DMD population. That's the official version I'm going to tell you today. You got to talk to your pediatric endocrinologist. I have another version later, but that's, I'm not going to be able to discuss that here, okay? Now, as we mentioned earlier, you have not only decreased linear growth, you also have an effect on bone mineral density. As your bone mineral density decreases, your risk for fractures increases, and that's osteoporosis. So now what are the things that affect that? One, muscle weakness. As I said, there's decreased tension on the bone, so there's less compression on the bone. Now, when you're not moving as much, again, there's less compression on the bone. So the bone doesn't build well. Even though you're building some bone, doesn't compact well, the structure's not well, so your increase for fractures is there. And of course, we're putting patients on glucocorticoid therapy, and that can increase their risk for fractures. Now, one of the tools that we use to measure bone mineral density is called a DEXA, and I really recommend that patients actually have a DEXA reasonably every year or every other year. And why is that? We're trying to measure the bone mineral density against somebody of their own age, and that's what the Z-score is. The Z-score is a valuable indicator for me to see what's going on in the trend. Now, when people have muscular dystrophy, their bone mineral density in the spine decreases. It also decreases in the hip, and it decreases in the wrist. So in all three places that are important, it decreases, so it needs to be monitored. And when when patients become non-ambulatory, their risk of fracture subsequently increases. Now, when people are on steroids, as I mentioned earlier, it decreases growth hormone, decreases IGF-1, therefore you decreased the cells that build bone, you slightly increase the activity of the cells that break down bone. You also have direct effects, as we mentioned, the steroids directly on the osteoblasts and the osteoclasts, and it also affects how you absorb calcium and how you excrete calcium. So it has multiple effects, and that's something to keep in mind why patients are at increased risk for osteoporosis. Now, in general, if you took a general population and you ask about their breakdown or where they have fractures, a lot of people have fractures in general in the vertebrae, in the hip, and in the pelvis. But the truth is that when one has glucocorticoid-induced osteoporosis, your increases are pretty much everywhere. So it's not as clean as possible, but one of the earliest things you're going to see is spine fractures. So that's why you need to look for x-rays, and which we're going to talk about next. So first thing is, you got to get labs. You go to an endocrinologist. The fun thing they always do is make you draw labs. You come to see me, I'm going to make you do labs every year, at least. And the other thing is you're going to get a bone density. And why we're looking at the Z-score, right? We're comparing your age and seeing what your bone density is compared to your age. Then I'm also going to get spine x-rays because that's among the earlier signs that we're going to get fractures. And that's why you need to get lateral lumbar, thoracolumbar spine x-ray. If you're on steroids every 1 to 2 years, and if you're not on steroids every 2 to 3 years. So the diagnosis is not going to be based mainly on your DEXA, okay, and I'll explain why. But in general, it's fracture history and Z-scores. Your fractures, just for picture's sake, you can have different kinds of fractures, so that's why I want to look at your x-ray just to see what's going on. But the reason you can't just go on DEXA is that when they did studies, whether they had a Z-score less than 2, meaning really concerning, or over -2, maybe not as concerning, you still had fractures. So I need both the DEXA and the x-rays. Now, there's no published studies on taking a medication to prevent fractures right now in DMD children or adolescents. The untreated fractures can lead to chronic back pain, so I want the x-ray so I can find out what's going on ahead of time, and if it's found, at least we can start the treatment immediately. So please, one of the things that I ask is that patients be on calcium and vitamin D early on, make sure their vitamin D is adequate, because as I mentioned, the steroids actually affects the absorption of vitamin D, and calcium, sorry, just calcium. So I want more vitamin D to make sure you can absorb more calcium. Next is, you can be treated with oral bisphosphonate or IV bisphosphonate. Personally, in the long run, in terms of fracture risk reduction, there's greater fracture risk reduction with an IV bisphosphonate than with an oral. So initially I may try an oral just to make sure you don't have side effects, but I'm going to eventually move you to an IV bisphosphonate. And I'll skip this slide, but there are pathways of whether I decide to increase or decrease your dose. And there are some complications which I'll talk toward the end of with the bisphosphonate therapy. So let's just talk briefly about adrenal gland. One is on steroids. As we mentioned, as Dr. McDonald mentioned, it ambulates more, has lots of effects, great effects on the scoliosis, minimizes scoliosis. It affects the respiratory tract. It affects the cardiovascular function. So there are a lot of benefits for taking it. Now, and people are on different doses of steroids. But one of the things that you have to keep in mind is, how do you, if there's an infection, if there's a significant amount of diarrhea, what do you do? And this is something that I make sure I ask everybody, which, if you've come to my clinic, I'm always annoying people. Please have a bracelet. Please have it on your phone. Please have a card, something. If there's an emergency, someone knows how to give you extra steroids. And also to, what are the signs and symptoms that you have to worry about? Well, one is you can actually have significant amount of weakness and tiredness. You can have anorexia or decreased amount of eating. GI symptoms, they can have diarrhea, nausea, vomiting. And there's a sick day protocol that I roughly give. If you're in clinic, I'm always going to give you one of these. So it'll be in your patient instructions, so please look at it, keep a copy of it in your card. Now, there's also for surgeries, there are some, you need to inform your surgeon if there's a procedure, what to do. And, if there is a procedure and you guys are going to have one, please tell me. We'll give you guys guidance on regarding how to manage that. So I'll briefly talk about, what its effects, steroids' effects are on hormones such as testosterone. So what happens in puberty, right? You have two different axes going on in the body. You have the adrenal gland that's producing androgens, and you have the testes that's producing androgens. This is the adrenal gland. This is the testes, okay, axis. And the adrenal gland produces DHEA and a little bit amount of testosterone, and that's the basis for the pubic hair, armpit hair, and acne initially that's seen. Now, in terms of the testes, you guys are aware that it produces testosterone. This is important for penis enlargement, testes enlargement, and sperm production. And this is the ages when I start expecting to see changes in the testes and scrotum, and changes in voice, lengthening of penis, and so forth, and looking at the hair. And these are the things that are important for you guys to be aware of. There is going to be some delay in this when people are on steroids. And when things are happening, it'd be great to let Dr. McDonald or any of your care providers know about it. If it's a delay, we want to be able to be aware of it so we can see when to initiate treatment. So one thing that I want you guys to be aware of, when people gain weight, it can actually lead to decreased testosterone levels. and increase estradiol levels. So that's why when you come see me, I always talk about, hey, weight management and so forth, because that can actually end up delaying pubertal development. Now, steroids can affect both the gonadal axis and the adrenal axis. So you end up producing less of the signals that come from the pituitary, and that stimulates the testes less, and you produce less androgens. Same thing happens here is that you end up taking the exogenous steroids. You end up decreasing, the body thinks, oh, you have enough steroids. I don't need to stimulate this adrenal gland to produce steroids. And that ends up producing less androgens there. So that's basically what happens. So that's part of the reason why one has delayed puberty. And not only does it affect in the pituitary axis, it actually affects directly the testes level also. You end up you affect the cells that produce the testosterone, and you end up producing less testosterone. So that's why it has multimodal effects. It's something to be aware of. So just knowing the physiology is useful. So when you come to see me, this is the same thing I'll be explaining. Or you see any other endocrinologist, it's the same thing they'll be explaining. Now, when you have decreased pubertal development, delayed pubertal development by the age of 14, we're going to start testing you for the axis, see what's going on in the adrenal axis and the gonadal axis. And we will do an x-ray of your hand just to see what the bone age is. Now, testosterone therapy can be given to people who are 14 years of age and older. Sometimes I give it even earlier than that, depending on the condition and the state and what we talk. Now, there are lots of benefits of testosterone therapy, including benefits on the bone. As I mentioned earlier, testosterone has an effect on the bone. And adequate androgens help lower fracture risks, lower loss of bone mineral density. The studies on fracture risk have not been proven. And there are different formulations. We can talk toward the end about the different kinds of formulations. Thank you. Any questions?
Hi, just a couple quick ones. You mentioned absence of pubertal development by 14 should require endocrinology consult. When you say absence, what Tanner stage? Or?
So when you're below Tanner 2, I start commenting, because normally most people are at Tanner 1 or Tanner 2. But if you're below Tanner 2, I start commenting. By 14, I expect to see Tanner 3, Tanner 4. So if I'm seeing a delay in that, then a referral to an adult endocrinologist or a pediatric endocrinologist, preferably a pediatric endocrinologist, would be great at that time period.
And then a slightly different question, which has to do with the DEXA scans. Is there some thought that there potentially may not be necessarily a great, how to say this, to take the typical Z-score from the general population and assume that is a good baseline for
so
boys with
Z-score is
DMD?
the Z-score is actually based from age appropriate. It's not necessarily based, as you said, but there's not enough data to say that, comparatively speaking, what it is. Now, there are some other methodologies that are being studied in research, but unfortunately, the insurance won't pay for them, even though I've tried to order them before, and so, arguments are hard with insurance companies.
Yeah. Okay. Thank you.
Thank you.
You mentioned growth hormone therapy in the setting of patients on steroids. Is there a serious discussion around that, or are the side effects too much?
The side effects aren't too much. There are serious discussions around it, but again, it varies depending on who the pediatric endocrinologist is. There are some studies that suggest there could be some benefits, but then there are others who will say that first, let's make sure the pubertal development is also studied along with that. So it depends on the timing of what's going to happen. Depends on your bone age.
Any other questions?
So official line is, yeah, at the time of fractures. Now, when you look at studies in other populations that are not in muscular dystrophy, we do start bisphosphonates at the time of, when we start steroids, but it's not necessarily, it's not been really well studied in children, and therefore there's a hesitation of starting bisphosphonate therapy early because we don't know what's going to affect on the bone growth. And, so that's why people delayed the start of bisphosphonate therapy till much later, till we have a clear indication for it. It may change in the future, but currently that's what the current guideline is.
Does UC Davis still have those emergency cards that they give in
Yes.
clinic to help out families? Like, thank you for mentioning about the steroid use if you're in an emergency,
Yeah.
the dosing and all that. Thank you.
Absolutely, yes.